morning, buongiorno, and welcome to this very beautiful Teleon stand in the green colour, which stands out nicely from all the blue and red we see everywhere. I'm Dr. Versace from Australia, good Italian name. I come to Milano from Sydney, and I've been invited this morning to talk about a topic I really enjoy, which is basically capsule fixation, rexus fixation of a lens, and to discuss how that may be a solution to some of the problems that we have with existing lens designs. You know, we've been using lenses for a long time. We have more than 200 lenses available to us in Australia. And you have to wonder, what is there left to invent? What's wrong with what we have? The original presbyopia correcting lens was put in almost 40 years ago, the Pierce lens. This was a zonal refractive lens and it worked really well. Patients got good vision. So 40 years later, what are we still trying to invent? What are we trying to talk about? And you know, the other way to think about it as well, why are so few of the lens implants that we see presbyopia correcting, despite all the lenses available to us? My financial disclosures. And let me begin then by presenting the problem as I see it, and this is real patients. Patient number one. This patient's a youngish nurse who insisted on really good close vision so she could read the vials, the ampules without glasses, so we chose a synergy lens, a full-strength, diffractive, multifocal lens. That works very well for these patients. And she had routine surgery, no problem, but she complained bitterly after her first eye was operated about poor quality vision. Bad for everything, distance and near, and she saw halos. Well, we expected that, but the halos were not even circular, so there was something wrong. We went through the normal process. Refraction was good, cornea was healthy, dry eye, not a problem, macula is healthy. So what's left? Well, I look at lens centration, alignment of a lens with the visual axis. And using the eye trace, which I think is a very useful tool for us in premium lens surgery, we find that her angle alpha, which describes the displacement of visual axis from center of limbus, angle alpha is only about 400 micrometers, kind of midway, not too bad. But when I look at her lens after surgery and where it's sitting in the eye, her lens is almost 700 micrometers displaced from the visual axis. So this synergy lens is very sensitive to decentration from the visual axis. The tolerance is probably about 400 micrometers. So we took her back to surgery after the first eye, and we nudged that lens to better align it with the visual axis. Now, I don't believe you can really shove a lens around and put it where you want it, but doing it a week or two later, the capsule is a bit sticky and you can achieve some movement of the lens. And this resolved her symptoms. She was happy. We proceeded with the second eye. So case number one that I've shown you. Case number two. Again, the problem. Here's a Vivity lens. This is not my patient. Comes to me with a problem, bad quality vision for everything. The eye looks fine. The original surgeon has gone ahead and done a capsulotomy because maybe that's why the vision is not so good. Well, it didn't cure the problem, but it turns out that when I examined this patient with the eye trace, the lens is almost 700 micrometers displaced from the visual axis. And again, this lens is fairly sensitive to decentration from the visual axis. So we didn't have many options here because the capsule was already open. So eventually we elected to explant the lens, put a lens in the sulcus, and this completely resolved the patient's symptoms. So this misalignment from the visual axis was the problem for this patient. So takeaway for me, number one, is that if we can somehow secure a lens to the capsular rexus that's aligned with the visual axis, we can solve a lot of these problems. We can now predictably align our lens with the visual axis. And there's no other way to do that. Problem number two that I will describe is the one of unwanted visual phenomena, halos, glare, these issues. Every diffractive multifocal lens has halos. It may not bother the patient, they may not complain, it may not stop them functioning, but they will have halos. And to be clear, the most important determinant of halo and glare is lens design. It's more important than centration or aberrations, it's lens design, and every diffractive lens will produce halos, it has to. And we can see that when we use a model, and we can plot that out over years of using a whole lot of different multifocal and presbyopia correcting lenses. And we can see that all the diffractive lenses have significant amounts of halo formation. So the second takeaway, which is almost how I can end the talk, is to say that if we use a non-diffractive technology, and in this case of the Teleon family of lenses, we're talking about segmental refractive lenses, we can potentially get rid of this problem of halos because it's a pure refractive design. What do we mean by alignment of a lens and centration? There's all kinds of things. Pupil, visual axis, centered with the capsular rhexis. You know, some people will tell you that you need a capsular rhexis that's aligned a certain way and that will control where the lens sits. Well, that's rubbish. It does not at all. The capsular bag, and then there's tilt. For this talk, I'm going to concentrate a little bit on pupil, but most importantly, alignment with visual axis. That's the one thing we must achieve with any premium lens implant. So let's go through it. It all gets very technical, but I'm going to keep it pretty simple for myself here. Visual axis. This is the point we want to know about. How do you measure it? You've got to think, how do you know where the visual axis is in a patient? The angle kappa that we've heard about forever with refractive surgery is not a very useful term. Angle kappa describes the displacement of the visual axis from the center of the pupil. Angle alpha is the concept we need to use. Angle alpha describes the displacement of the visual axis from the limbus, or the center of the capsular bag. So this is most relevant to lens implant surgery. And here's what it looks like on the eye trace. Visual axis in the middle, and it shows us angle kappa and angle alpha. And this is what I can do with eye trace. I can take a patient after surgery, and I can actually look at the lens, and I can see where the visual axis is in relation to the optic of that lens. And here's a segmental refractive lens with the visual axis going perfectly through the distance vision segment of the lens. Let's get rid of the idea of pupil alignment first. It does matter. The pupil alignment with the lens does have some impact. It's not the key thing, but it does have some impact. There are case reports for diffractive lenses where patients present with bad vision. They're observed to have chorectopia, so the pupil is not aligned with the rings on the lens. The surgeon takes the patient to the argon laser and does a pupilloplasty that drags the pupil to a new position and aligns it with the rings on the lens. The patient's symptoms are resolved. So we know that the pupil in this case was causing problems. Now you probably shouldn't do this because over time an argon laser pupilloplasty will give you iris transillumination defects and the pupil will drift back anyway. But it just shows that pupil position certainly can matter. If we look, for example, at the segmental refractive lens, the Teleon family of lenses, pupil position can matter. And we need to think about it. If the pupil is really decentered, there's a big chorectopia, look what happens as the pupil gets smaller. It'll have an impact on the allocation of vision for far and near. Now, it's amazing we ever get away with using lenses because we never get perfect alignment with visual axis and the pupil. But the pupil is not the most important thing. It's the visual axis. Let's go there and talk about it. There is data published that shows that if a lens is misaligned with the kappa, the big kappa decentration, so if there's a large angle kappa, you'll get a lot of unwanted visual phenomena. This has been published, there's a number of papers out there. So there's clearly an association between the size of angle kappa, which is not what we should be concentrating on, to be clear, but there is an association between a large angle kappa and unwanted visual phenomena with multifocal lens implants. But it's not a clear relationship. Why is that? Well, first, because angle kappa is not a very useful parameter. It's loosely associated with the visual axis, but it's a very loose association. Secondly, there's an issue where the anterior chamber depth will give a different impact for a given displacement of angle kappa. So the lens is further away or closer to the cornea, a certain size angle kappa will have a different impact. So angle kappa has a variable impact on unwanted visual phenomena. And it gives us this concept of a critical angle for angle kappa. And maybe it's around 11 degrees, a displacement of 0.7, almost 1 millimeter. But in a normal population, angle kappa is normally about 5 degrees, something like this, with a typical displacement of less than 0.5 millimeter. So it's rare that we get to a critical value for angle kappa in a normal population. Another publication that's really quite interesting demonstrated that there's a very clear correlation between the size of angle kappa and unwanted visual phenomena, as in halos and glare, with a multifocal lens implant. In this case, the Zeiss trifocal lens. And this paper showed that you've got a very clear association. So if you have increments of angle kappa, as shown on the right there, the amount of glare and the amount of halo goes up with a statistically significant increase for each increment of angle kappa. But it has no impact on spectacle independence and visual acuity. So, we have to be sure we're not just relying upon spectacle independence or visual acuity to assess patient outcomes, of course. The other thing to know is that angle kappa is not a fixed figure. Angle kappa changes after lens implant surgery. Right? This is shown, this is published. So, whereas angle alpha is fixed. So here's angle alpha, which is the concept we're going to talk about now because that's the most important concept for us with lens implant surgery. Angle alpha is quite a constant value, typically about 0.4 millimeters, pretty much always nasal, and pretty much always on the horizontal axis with minimal vertical displacement. But this slide I've put in yellow because that's one of the important takeaway messages for you from this talk. And this message is to say that angle kappa changes after surgery, pre-op to post-op. You can see that it's a different distribution of angle kappa. And it's probably because the way the iris is different with a lens behind it, and surgery can impact the exact pupil position. So angle kappa is not a fixed value. So when you measure it before and after surgery for the position of a lens, it is not a useful thing to do. Whereas angle alpha is extremely constant. It does not change with surgery. That makes sense because angle alpha is the relationship of the limbus, which is a fixed feature with the visual axis. So use angle alpha when you think about this stuff. What can lenses tolerate? Well, monofocals, of course, can tolerate almost 1 millimeter of decentration. It's very non-critical. Diffractive multifocals, I would say that about 0.5 millimeter is your limit. And if you go beyond 0.5 millimeter of misalignment from visual axis, some patients will have problems. And a larger pupil, of course, will matter. So what can we do about it? I've spent some time talking about the importance of alignment of a lens with the visual axis. What can we do about it? Well, you'll hear as you go around people talk about just pushing the lens a bit nasal at the end of surgery so that you align it with the visual axis. I'm going to tell you that's a total waste of time, okay? Here's me doing that first case. That's a week after surgery, so the capsule's a bit sticky, so maybe I was able to move it a little bit. But here's a paper published a couple of years ago that looked specifically at how beneficial was it to try and position a lens at the end of cataract surgery aligned with the visual axis. And basically they came out saying it was a waste of time. There was no difference between the two groups. One group, you put the lens in, let it sit where it wants to sit. The second group, you put the lens in and you deliberately try and put it in a certain position. When you look at these patients afterwards, there was no difference. It's a waste of time, okay? So if we cannot put a lens where we want it in the capsular bag, what can we do about alignment with visual axis? Nothing. Nothing with a symmetric lens. But if we use an asymmetric lens, like the Teleon family of lenses, that's what I'm here talking about, look at the sign, we can do something about it with these lenses because we can select how we're going to position that asymmetric segment of the lens. So we do now have some control over how to align an asymmetric lens with the visual axis. And this just shows that, if the visual axis is displaced, well, put the lens in a different position. And then if we go a step further, if we can align the lens by having it attached to the capsular rhexis that we have created aligned with the visual axis, we now have perfect alignment every time with the visual axis. No variability. It has to be aligned. And that's what this family of lenses can do, both by being asymmetric and then some of them, the Femtis lens, being attached to the capsular rhexis. And it's a whole family of lenses, hydrophilic and hydrophobic, monofocal, toric, low-powered EDOF, high-powered MF30. So it's a family of lenses with similar optical design. And I'm going to talk a little bit about the Femtis lens because to me, this is a very exciting concept. Being able to attach a lens to the capsular rhexis gives us benefits that helps to resolve some of the problems that we have with existing lens implants. Surgery is not hard. This is just like routine lens implant surgery. The lens goes through a 2.2 wound, you put it in the bag, and then you attach it to the capsular rhexis margin. It adds about 45 seconds to surgery, so surgically, this is not a problem. But you do need a good capsular rhexis, of course, and we'll come to that. So you need to use a femtosecond laser to create your capsular rhexis. You need a perfectly circular rhexis of a given size, maybe 4.9, 5.1 millimeters, somewhere around there, so the lens will attach easily, but be securely attached to the rhexis. How do you do this? Well, there's many ways to create a capsular rhexis. There are a number of femtosecond lasers we can use. Next to us here, we have the Lens AR Alley, which is a beautiful laser, a very modern femtosecond laser for doing cataract surgery. Have a look at it. There are many systems. We can use Zepto, we can use capture laser. We can even do a manual capsular rhexis. Now, I would not recommend that because it's very difficult to always create a perfect 5 millimeter central round capsular rhexis manually. But we want to align the lens with the visual axis. So when you create your capsular rhexis, you want that aligned with the visual axis if you can. Let's look at two features of this lens, the Femtis lens. The first feature is to understand the benefits of attaching it to the capsular rhexis. And the second benefit is this idea of segmental, pure refractive optics as a technique to get rid of unwanted visual phenomena. We did a study that was published a couple of years ago now of the Femtis lens to look at these features. And of course, refractive predictability is excellent, as you'd expect, because you have very predictable effective lens position. A lot of patients, of course, get visual freedom, spectacle independence. And the defocus curve is interesting. So for this segmental refractive lens, the defocus curve is very much like existing EDOF lens technologies, very much like Symphony, but a bit broader, so a little bit better. So this lens is falling in this area, a very complex kind of chart, but basically it's saying we want to use a lens that has good quality vision, no compromise for distance vision, minimize unwanted visual phenomena, but optimize the range of vision. And that's where we're looking with this segmental refractive optical design. And for this study that is published, we had 60% of patients basically did not wear glasses. That's fantastic, right? And the rest just wore reading glasses sometimes. That's a very good outcome. When we look at the defocus curve, well, it's like the best of the EDOF lenses out there, really. It certainly outperforms a lens like Eyehance or Vivity. How does a lens achieve that? Because it looks very much like a bifocal lens with two refractive elements. And it's kind of complex to get your head around how this lens can behave like an EDOF. We're working backwards a little bit here because we have the clinical defocus curves, and there's no question these defocus curves that we're seeing are EDOF defocus curves. There's no dip like a bifocal lens. So we work backwards to try and explain this. And the way to understand is to think about if you create a defocus curve experimentally, measuring MTF, modulation transfer function. Typically, when you see industry data, that's always measured in just one axis, either horizontal or vertical. But if you start to measure the MTF in multiple planes, that's how you get the EDOF properties. I'm going to try and demonstrate that. So with this segmental, refractive, asymmetric lens, when you try and measure an MTF in one axis, it's different to when you measure it in another axis. You will get a different kind of defocus curve for these two measurements. If you do the same thing for a symmetric lens, which is pretty much every other lens, all the diffractive lenses, all the other EDOFs, whether Vivity, Eyehance, when you measure the MTF in different axes, it has to be the same in every axis because the lens is perfectly symmetric. So it doesn't matter how you measure it, you will get the same MTF curve. Now we can model this, and we can model it both mathematically and on the optical bench. And when we look at it, up the top is for a symmetric lens, so a diffractive EDOF symmetric lens. When you measure the modulation transfer function to generate a defocus curve horizontally and vertically, it's the same in both directions because the lens is symmetric. And when you mathematically summate those, you get a kind of bifocal curve. With the segmental asymmetric refractive lens, when you measure the MTF in two different planes and you add it mathematically, you get what looks like a EDOF defocus curve. This has now been published, and what this group did was experimentally they modeled mathematically to say what will happen, and then they also did the experiment on the optical bench. And same thing, when you add the defocus curve, taking the MTF in different planes, and you add them together, you end up with what looks like an EDOF defocus curve. For a bigger pupil, it looks different, of course. But for a typical pupil size, this is like an EDOF defocus. That's how this apparently bifocal optical design can behave as an EDOF lens. And certainly in real life, that is what we observe. There's a defocus curve for the lens I'm talking about. Here I'm talking about a Comfort, which is MF15. Same optical design across the whole range of lenses. And we're getting a defocus curve that gives you a greater volume underneath it, which is a good way to express the amount of vision a patient has, the volume under the curve, and it's outperforming the competitive EDOF lenses. Equally importantly is the lens does not create unwanted visual phenomena. So again, here's the diffractive multifocals, including Symphony, an EDOF diffractive lens, and there's the Femtis EDOF lens over on the very right. You just don't get halos with this optical design. Now that's both the optical design and having it affixed to the capsular rhexis, so in a good position behind the iris. You need to create a good capsular rhexis, so you can use a femtosecond laser, like the Ali lens arm, or you can do a manual capsular rhexis. Don't do it. I got lucky this time. My laser went down. The patient had been promised a Femtis lens, so we did a manual capsular rhexis and got away with it. But it's very difficult to consistently create a perfect capsular rhexis every time manually, so I would not recommend that. Zepto was popular for a while as being a portable, low-cost device, but it's kind of falling from favor a little bit as being a bit cumbersome and having its own particular problems. Zepto device, yeah, it was an appealing concept. Capsule laser is now gaining some inroads. This is a fantastic concept. With capsule laser, we have a very cost-effective way to create a perfect capsular rhexis using different technology completely. I would say the technology is not quite there yet in terms of how the energy is delivered, but I think the concept is fantastic and potentially will give us a cost-effective way to create a capsular rhexis, which will allow us to use more Femtis lenses. And of course, capsule laser also has the benefit of giving us a stronger capsular rhexis than we can create manually or than we can create with a femtosecond laser. Not such a big deal. Capsular rhexis strength, theoretically, yes, it would be nice if it was stronger. But in practice, we can fiddle around with the Femtis lens when it's attached to the capsular rhexis, and you're not going to damage it unless you're very rough. So, in summary, I would say that aligning and attaching your lens to the capsular rhexis is going to help solve some of the problems we have. You will not get negative dysphotopsia. You'll get alignment with visual axis in a very predictable manner. You're not going to get capsular phimosis. We are probably going to see improved refractive predictability when we get bigger numbers, simply because we have a more predictable, effective lens position. We won't have tilt, and we're going to minimize unwanted visual phenomena. And the segmental refractive lens design that we're talking about here across the Teleon platform of lenses, by being pure refractive, is going to minimize unwanted visual phenomena, high quality distance vision, and we have a true EDOF lens design. My last slide, if I can say one thing, it's if you have an angle alpha showing a displacement of greater than 500 micrometers, don't use a symmetric, diffractive, multifocal or EDOF lens. because you have a high potential for a poor outcome. And if you're using a segmental refractive asymmetric lens, one of the Teleon lenses, and you're not doing rhexis fixation, so using a standard lens in the capsular bag, maybe think about placing the near segment infratemporal if you don't want to have to concentrate on what you're doing. That way you have the greatest chance to align the visual axis with the distance vision aspect of the lens. That's my talk. Thanks so much for coming along early in the conference and listening, and I welcome any questions.